Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse, as well as CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can re-watch all of our educational programs by going to the section of our website called Education on Demand. We would like to thank AstraZeneca, Pharmacyclics, and Janssen for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, who is CLL Society's Executive Vice President and Chief Medical Officer.
Thank you, Robin. I'd like to welcome our audience and speakers to today's event. We are joined by patient advocate Glenn Sabin, who was diagnosed with CLL back in 1991 when there were very few options for treatment. Glenn dramatically altered his lifestyle and diet with positive results. And though, as he explains, he's an N of 1 and that worked for him and may not work for others, he will share his experience with you today. Dr. Gordon Saxe is a preventive and integrative physician at the University of California, San Diego. And he's going to provide some advice about chronic disease management to help people prevent and treat their disease through integrative and lifestyle medicine, and have some good dietary advice. Dr. Andrea Sitlinger is an assistant professor of medicine and hematology oncology at Duke University School of Medicine and Duke Health. And she's going to talk about information around exercise and a recent study where she was the principal investigator involving CLL patients and high-intensity training. CLL Society encourages all patients to discuss with their healthcare team about what would be their best approach to diet, exercise, lifestyle changes, and possibly supplements to help with the management of their CLL, SLL. Healthy decisions can be very beneficial, but should always be coordinated with the doctors and their teams who are managing your CLL, SLL. We would like to start by welcoming Glenn Sabin to share his journey with CLL.
I was diagnosed 31 years ago. I was 28 years young, newly married, had my entire life in front of me. And I was told I had this older person's disease and that it was incurable. Back then, CLL was just one bucket. So one treatment, one size fits all. And there was no immunotherapies. There were no targeted therapies, no monoclonals. There was no genetic prognostication assays. We weren't looking at IGHV. FISH didn't exist. And the standard of care treatment options were essentially a cocktail of chemotherapies with prednisone. And there was an experimental bone marrow transplant that conferred a 20% mortality rate. And then there was something brand new that they wanted to call watchful waiting. But before any treatment decisions were made, first I had to deal with a 6-pound spleen. My spleen was filled with about 4.5 pounds of leukemic cells. So after a splenectomy, I decided that instead of watchful waiting, that I would go with proactive observation, which is a term that I coined early on because I felt that watchful waiting was and remains more of a reaction type of situation, like a sitting duck, and that wasn't going to be me. So I embarked on a long journey to discover different things that I might do to better support myself and to participate in the management of the disease, and more essential, the management of my health. So I learned about nutrition and movement, sleep hygiene, hydration, relaxation, supplementation. And you have to keep in mind that these were the pre-internet days. So I had to do it old school. We're talking bookstores and libraries to get my information. And so I took this path with this kind of regimen that I cobbled together, and with the support of a couple of nutritionists and pharmacists along the way. And I went down this for the first 12 years of my journey, doing quite well, asymptomatic. And in 2003, in the summer of 2003, I became sick for the very first time with a very acute episode, full-blown leukemia. I had a Coombs positive hemolytic anemia with night sweats and incredible fatigue and a low-grade fever that was just unabating. And the only thing that changed in terms of therapies during that 12-year span since my diagnosis was the addition of a monoclonal antibody, rituximab. Nothing else had changed, and I was very disappointed that the science hadn't caught up to the disease. And at that point, I refused standard of care because standard of care was absolutely palliative. And I wanted to just see what I might do and what I might change with this little experiment that I had going on to see if there would be any effect, any impact on, on the disease, on my blood counts. So over the course of about 14 weeks and under the supervision of a Harvard, my Harvard hematologist, my Johns Hopkins physician, I would go ahead and be seen in clinic twice a week for blood work, for CBC, CMP, just to see where I was at, because I had a very low hematocrit. And over this period of time, about 14 weeks into it, the blood started changing, and eventually it normalized. It normalized to a point where I was in remission, systemic remission. The only way you could tell that I had disease was to look at it subclinically, pathologically, by going into the marrow. And even the marrow was reduced by about 50% of the disease burden. And this partial remission lasted for 6 years. Then in 2010, disease was once again visible. And I started working with a new integrative oncology expert. And over the course of about 14 months, my marrow was totally cleared of leukemic cells. So it was a full, complete remission, what we call deep and durable remission, that has lasted so far for 10 years. I reached the 10-year mark this past January. So during the 31 years since diagnosis, I've had a couple, remarkable clinical responses documented by a Harvard Medical School dean and now published in the literature. So you may be asking, well, what should my story mean to those living with CLL? Well, first, it's important to clarify that if today's highly targeted and effective therapies were available today, therapies for some that can be like a functional cure, if they were available to me, then I would have taken these drugs for sure. But what I will say is that this is the time to focus on the host. These targeted therapies focus on the disease burden, on the tumors. The host is you and me. We are the hosts. So taking the time during a period of, let's call it watchful waiting or proactive observation, this is an important window to work on things to improve your immune function and resiliency, to create an anti-cancer lifestyle and habits for you to be able to create your healthiest self despite an underlying diagnosis of chronic lymphocytic leukemia. And especially in light of COVID and the next pathogens sure to come. So I know we're going to be hearing from Dr. Sitlinger on her recent exercise study with CLL patients and high intensity interval training. We're also going to hear from Dr. Saxe on nutrition and supplementation. I'm looking forward to hearing them speak. But I want to say that in 1991, this science didn't exist around these different lifestyle and behavior change. But eating well and moving your body, hydrating, etc., these were all smart and prudent to do then, and they're especially so today. Today, we know so much more about lifestyle's impact on immune function and resiliency, and I encourage you to be your healthiest self, your most resilient self, who happens to be hosting an underlying diagnosis of CLL.
Thank you, Glenn, for sharing your remarkable story with us. We now welcome Dr. Gordon Saxe.
In today's presentation, I'd like to talk about two things. The first thing is a little bit of the background and science on how diet is related to cancer and how it might be used in the prevention of cancer. And second, I'd like to leave you with some practical guidelines on what you can do to potentially help prevent cancer, or if you're suffering from cancer, to be able to reduce the magnitude of the problem. When I was a young man, my conception of cancer, like probably most people's, was that it was a random event, that if you were unlucky and you had inherited bad genes, or you got inadvertently exposed to some type of chemical or carcinogen or radiation, that you would then have the misfortune of developing cancer. It was like a bolt from out of the blue. And there really wasn't much you could do about it other than submit yourself for screening to try and detect it as early as possible. And if you had it, submit yourself to treatments. And many years ago, when I was first getting interested in this whole area, at that time, treatments were not what they are today. And they had the reputation then of being either disfiguring or toxic, and possibly even worse than the disease itself. However, something happened when I was just out of college that forced me to really rethink all of this. What happened was that my dad, my beloved father, was diagnosed with cancer, and we were told by his doctors. I lived in Baltimore at the time, and my parents did, and he was seen by his doctors at Johns Hopkins, who told him that his life expectancy, the cancer had already spread, and his life expectancy was measured in all likelihood in months, not in years, that he had less than a year to live. And I was a brash young man, and I wasn't going to take my dad's doctor's word for this. I was going to find out and try and do anything that I could, anything to help my dad to get better. So I went down to the medical library at Johns Hopkins and immersed myself in anything that I could find on the relationship on cancer in general, and on its relationship with diet, lifestyle, anything that could be of help. And now, mind you, this is in the early 1980s, but things that started to pop out of my searching were really quite amazing. One thing that revealed itself was that even way back in the early 1980s, it was already known that the rate of cancer varied dramatically around the world. There were some countries, especially those in Southeast Asia and in sub-Saharan Africa that had very low rates of cancer, whereas they were dramatically higher for many of the common types of cancer, breast cancer, prostate cancer, colon cancer, and so forth. They were much higher in other parts of the world, usually westernized nations like the United States and Canada and the United Kingdom and so forth. In this graph, what you see is the relationship of the death rate from breast cancer in a number of countries when it's correlated with a factor that also tends to reflect, to be an indicator of different dietary patterns around the world, namely the amount of dietary fat. And you see some countries like Thailand in the lower left that have low intake of fat and also very low death rate from breast cancer, and others like New Zealand up in the upper right that have very high intake of fat and very high rates of breast cancer. Now, this is not to indicate that fat per se is the problem, only that it's a marker maybe of an overall dietary pattern or some other factors that could be potentially more causal. But in any case, it certainly raised intriguing questions. In the lower left, you might notice, curiously, one country in particular, Japan, that has low intake of fat and a different dietary pattern than in the other westernized countries, and low rates also of breast cancer. Now, in my earlier way of thinking, I thought that it was things that got zapped on you, genetics or exposure to a carcinogen or something like that, maybe something you breathed in. But here, Japan, even at the time that these data were developed, was a very industrialized country, a very crowded country with lots of stress, a lot of pollution, a lot of things that themselves you would think might increase risk of different types of cancer, including breast cancer. And yet their rates were very low. So it's a curious kind of thing. And we've also learned since then that when Japanese people migrated to the United States, the migrants themselves, even though they were genetically or ethnically, they were Japanese, when they came to the United States, their rates went up. And their children, a Japanese man, Japanese woman, had a child still genetically, quote unquote, Japanese, their rates were the same as Caucasian Americans. So something here in the United States and other Western countries in the water, so to speak, maybe is an important factor. Now, as I was looking to try and understand how did diet relate to cancer in general, one of the things that I discovered, I came across in the literature, was something called the initiation and promotion theory of cancer development. Initiation refers to the first step in the process where something happens that damages a cell, that gets into its DNA or alters its DNA, causes a mutation. And as a result of that, the cell then has the predisposition under the right circumstances to grow into a cancer. But it still requires a second step, promotion. Promotion refers to when a mutated or initiated cell is then exposed to an agent that causes it to proliferate and then causes it eventually to form into a tumor or a cancer. But one thing that was discovered along with the initiation promotion theory and experiments was, interestingly, that if we remove the promoting factor, the factor that's causing the replication of these initiated cells, if we remove it, sometimes the process will stop. Sometimes we may be able to slow the further growth of the cancer. And sometimes it may be possible to even stop it, to arrest it altogether, and in a few cases, to even cause it to regress, to go away. So this all is a very hopeful thing because it suggests that if we could figure out what we might be exposed to or inadvertently exposing ourselves to that is promoting cancer to grow, and we could find a way to effectively remove it, we might be able to help get a handle on the condition. So you might think of these mutated cells, like individual pieces of grass, and the cancer itself is akin to an entire lawn. And in conventional medicine, we're highly skilled at mowing the grass, at removing the cancer cells. Not perfect, but we've gotten very good at this. Now, I would add, maybe we should also try to stop overwatering the lawn. I think if we don't do this, we may be approaching cancer with one hand tied behind our back. So what are the promoting factors? So number of factors have been looked at with respect to diet, and these include a nutritional factor, obesity, also excess calories, and many others. I want to touch on a couple of these. Obesity, overweight and obesity, which is defined as having a body mass index greater than 30, and that's a measure of weight for height, that when people are obese, their risk of developing certain cancers is increased. And if they already have that cancer and they continue to be obese, their risk of having a relapse or succumbing to the cancer sooner is also increased. And there's growing evidence that weight loss, achieving our ideal body weight, especially if we do it in a healthy way, may be able to reduce our risk of certain cancers and possibly to slow or improve the outlook, slow the cancer or improve the outlook and long-term survival even after diagnosis. When it comes to calories, we've learned that for over a century, that excess calories when fed to poor little lab animals cause tumors to develop or accelerate. Now, this occurs, the work of a researcher named Tannenbaum in the 1940s, that long ago, found that when mice were exposed to certain chemicals that could cause cellular mutations or exposed to radiation or other factors that could damage the DNA and essentially predispose or initiate cells, that when those mice were then either fed excess calories or a calorie-restricted diet, the mice fed excess calories were much more likely to develop tumors, and if they got cancer, to develop much more rapidly progressing cancer. So calorie restriction is another way of that we've learned that we may be able to remove a promoter in essence. When it comes more specifically to chronic lymphocytic leukemia, CLL, the data here is more limited. Perhaps it's not, CLL is not as common a condition as some of the more frequently encountered cancers like breast and prostate and colon. So there's not as much research has been conducted, but we're beginning to see even here that Western diets, like the ones that I was showing in the earlier slide about breast cancer and prostate cancer, have been linked with higher incidence of CLL. Obesity may also be a risk factor for poorer outcome. And because of this, we here at the University of California, San Diego, are interested in researching this connection, and we have research that we're considering right now that would examine this in more detail. I want to now switch gears slightly and show you about research that my group, when I was in my residency at University of Massachusetts, that we conducted a number of years ago on the effect of adopting a whole food plant-based diet coupled with stress reduction like meditation and yoga on what happened with the progression of advanced prostate cancer, where the cancer has spread beyond the prostate and is measured by a rise in a biomarker called PSA, or prostate-specific antigen. We looked at a group of men who had advanced prostate cancer who were referred to us by urologists at University of Massachusetts, and we enrolled them in an intensive program for several months where we taught them cooking classes and we worked with them intensively to learn about meditation and stress reduction and dietary counseling, things to support these changes. What we see in this graph is the results for a number of the subjects in the study. And each pair of bars is a subject. So The bar to the far left, or actually two bars, there's one that's light blue and one that's a darker brownish red. The light blue is showing how the cancer was doing before the intervention, and the darker red-brown is showing what happened during the intervention. So this is based on the change in the rate of increase in their biomarker of the cancer, PSA. So you see for every combination, for every subject, with one or two exceptions, there was a lessening of the rate of progression during the intervention period. And you'll see that for a few of them, the first, the second, and I'm not sure which one that is closer to the far right, you see that those brownish red bars drop below the 0.0 mark. That's saying that the cancer not only stopped growing, but based on the PSA, it actually appeared to have possibly been reduced. The volume in the body of the cancer may have actually gone down. In other words, possible shrinkage of the cancer because of perhaps the intervention that they underwent. Now, you might be thinking, well, this hasn't been proven for CLL yet. And so why change diet? It's not necessarily the easiest thing to do. And one thing I learned with studying prostate cancer is that men with prostate cancer, most men with prostate cancer may actually have equal to or greater risk, an equal or greater risk of developing and dying from heart disease. And so here is an angiogram on a patient, or actually a pair of angiograms. The one on the left shows the status of the left anterior descending coronary artery that feeds the heart. That's the main artery that feeds the heart. You see how it's all squinched up and narrowed at the bottom? This is in an individual with severe coronary artery disease. And when you see that pattern is referred to as the widowmaker, because it often occurs in middle-aged or older men who then have an acute heart attack, and then it leaves their wife a widow, the widowmaker. Well, fortunately, this one individual who was in one of the studies that was done on the effect of diet and stress reduction, diet and lifestyle change on heart disease, made major changes in his diet. And 32 months later, when he had a second angiogram, you could see that it was completely restored to normal. Good blood flow again. That narrowing had disappeared, and blood flow and all measures of circulation had improved. So we have pretty solid evidence now that this is good for the health of the heart, for circulation, for preventing heart disease and heart attacks, and also other conditions. And it may be helpful, may, for CLL and other cancers. So I don't think there's any harm in doing this, only potential benefit. Now, I'd like to switch gears again and talk about what you can do to help reduce your risk of developing cancer. We have put together a program at UC San Diego based on what we call the 5 pillars of a cancer preventive diet. We believe that ideally, one's diet should be based on whole foods that are unrefined and unprocessed. The diet should be plant-based, and that means that the foundation of the diet should be plant foods. It doesn't mean you must be a strict vegan or that you can't wear leather shoes, only that the foundation of your diet should be plant food. As much as possible, we think our diets should be foods that are grown locally or regionally and in season, and therefore better adapted to us and the time of year. If possible, we want them to be the highest quality, organic when possible, or biodynamic, or at least sustainably grown, healthier soil. And we want our diets to be balanced, nutritionally balanced, but also balanced in terms of the visual, a rainbow of colors on our plate, a variety of different types of foods. Not everything should be boiled, or baked, but a variety of cooking methods, a balance of things, and according to our individual need and the season of year. So here are some foods that we think have possible anti-cancer properties. First and foremost, whole grains, variety of vegetables, beans and legumes, also fruits, seeds, and nuts. dark leafy greens, which are also excellent for heart health, brassica or cabbage family vegetables like broccoli, cauliflower, kale, and collard greens and bok choy, allium or onion family vegetables, certain kinds of mushrooms called polypore mushrooms, not so much the standard white button mushrooms you might see in the supermarket, but ones that are becoming increasingly popular like shiitake and maitake. Sea vegetables, like you might have seen on the wrapper in a Japanese restaurant, the wrapper around the sushi or the little delicate fronds in the miso soup. Sea vegetables are can provide every single mineral required by the human body. And it's about the only food on the planet that can make that claim. Sea vegetables also have demonstrated a number of anti-cancer properties in studies in Japan for decades. Fermented and probiotic foods that are healthy for the gut microbiome to help build dynamic health in our gut and throughout the body. Green tea, a compound that may actually be preventive or helpful for CLL, contains a compound, a potent antioxidant called EGCG, which may be helpful for cancer prevention, and various herbs, for example, turmeric. Now, putting this all together, you might think, well, I don't know. I don't think I'll be missing all my healthy food or my normal foods. So I'm eating something healthy. Brilliant, cold porridge and stale bread again. No, that's not what I'm talking about. I want to leave you with a few images of what it can look like. So first, here's one of my favorites, brown rice, a medley with shiitake mushrooms and garnished with a little green vegetable like maybe scallion or parsley. Dark leafy greens, like a bok choy, that is then topped with some or crowned with some roasted garlic. Here's another one, a vegetable medley especially rich in the cruciferous vegetables or the brassica vegetables like cauliflower and broccoli. Beans and legumes, which are very high in fiber, good for blood sugar, and have a number of other beneficial properties. And for dessert, dark berries. Now, before I finish, I want to leave you with one other thought. Now, this is a shameless plug for a study that we are planning to undertake at UC, University of California, San Diego, in individuals with CLL. As some of you may know, because of COVID, vaccinations, a lot of people are have immunity against COVID now, but unfortunately, the vaccines are not perfect. And for people who have some degree of immunocompromise, including people with CLL, they may not work or they don't appear to work as effectively. And some people, even if they get vaccinated, they can't produce antibodies to protect them or as many antibodies. Well, we think it's possible that by using a nutritional factor, specifically the same polypore mushrooms as I was talking about a moment ago, but in this case, using them in a dried form in capsules and taken for several days, that by doing this, we might be able to give a little boost to the immune system at a critical moment when a person is undergoing vaccination for COVID, and thereby increase the effectiveness of the vaccines. So our question is, can doing this result in an increase in antibodies and improve overall vaccine response when a person gets COVID vaccination? So our plan is to undertake the gold standard of trials, a double-blind, placebo-controlled, randomized clinical trial here in San Diego and also in Los Angeles and Southern California, but it may involve recruitment at sites beyond Southern California. We haven't yet finalized everything. We've been in discussion with the CLL Society, and when we get a little closer to the start date, the Society has told us that they'll share information about the study as it becomes available. So if you think you might be interested in this, or someone you know might be interested in this in the future, then keep an eye on the website for the CLL Society and other communication, and you should hear more about it in the next couple of months. Anyway, thank you so much for the opportunity to speak with you this morning. And I'd like to now introduce our next speaker, Dr. Andrea Sitlinger.
Hi, everyone. My name is Andrea Sitlinger. I am one of the CLL and lymphoma doctors at Duke Cancer Institute. And thank you so much for allowing me to be here with you today. I'm really excited to talk about this topic and look forward to chatting more at the end. But I want to jump in because, of course, I could talk for hours on this and I only get 15 minutes. So we are going to be talking about CLL and exercise and physical activity. So my objectives are kind of to go over exercise, go over understandable the difficulties that our CLL patients particularly face, how we potentially might benefit from CLL, and then how exercise or exercise may benefit our CLL patients and how it can be feasible for you. So why is physical activity beneficial in general? I love this little cartoon or graph because it really shows how physical activity affects all areas of your health. And so when we look at studies pooled together, we see improvement in how your brain's functioning, how your body's functioning, how you're feeling, and actually see improvements in mortality, so your long-term survival, as well as how improvement in your cardiovascular, your diabetes, which I don't think surprises anyone, but even in some cancers, we are starting to see that you actually have improvement in survival of your cancer, regardless of the treatment, just because people are physically active. So for all of that reasons, we really want to help our CLL patients be active to not only help with their cancer, but help them feel better in all areas of life, especially because we are hoping that all of our CLL patients are living long, long lives. So we worried because understandably, CLL patients have lots of reasons to be less active. And that's because, of course, some of the symptoms, some of the fatigue and all of the symptoms that can come with having CLL. And so we did a look in our clinic and did some surveys of how physically active patients with CLL in our clinic were. We looked at grip strength. We looked at how fast people could walk in 6 minutes. And then we looked at how fast someone could get up from a chair. And then we looked at some other stands, like chair stands, balance testing, and how quickly someone could walk 4 meters. Based on all of these tests, we could then calculate something fancy called a VO2 peak, but basically that just measures your aerobic fitness. So how well your body can do with cardiovascular activities. And what we found after we did this for over 100 patients was that our CLL patients were able to do all of these assessments, and that the surveys correlated with each other, meaning kind of how patients estimated their activity levels were. But that our patients, unfortunately, when we looked at their activity levels compared to normative levels, which means patients around their same age, that our patients were 48% were inactive or engaged in very light activities. So over 50 of our patients really weren't doing much activity at all. And only about 28% of our patients did moderate activity. So most of our patients weren't doing a whole lot. And when we looked at our aerobic capacity or strength, which is that VO2 peak I was talking about, it was only 64% of the patients' values of what would be normal for their age. So we were seeing some serious deficits. And then the other thing is that we saw that the measures of the objective measures that we were looking at when we looked at the strength testing I was telling you about, or the balance, or how fast they were walking, didn't necessarily correlate with what they were saying on their surveys. Now, that doesn't mean our patients were lying at all. It just means that in general, when we are thinking about our physical activity, sometimes that might just mean that we're perceiving that we're doing a lot more than what we actually are. And that might just possibly be for many reasons, and that's something we're exploring. But one of them is the fact that CLL can make you feel poorly, you know, the fatigue and night sweats and all of that thing. So that can mean that even those minimal activities can feel like a lot. And so for us, this really identified we have a patient population that we could perhaps really help by just helping them be able to do more. There are other trials out there. They're very limited in CLL, unfortunately, and there's a lot more in the breast cancer world and some of the other cancers. That's why you saw that graph earlier. But one trial that looked at exercise and physical functioning and quality of life in general lymphoma patients did recruit CLL patients. And what they did is they had an intervention where they rode on the bike 3 times per week for 12 weeks. And they were slowly increasing the intensity of the biking, so keeping it hard. And they found that patients enjoyed significant improvement in quality of life, fatigue, happiness, depression, their cardiovascular fitness, their physical functioning. And even after 6 months after the intervention, they still found that they were experiencing improvements in quality of life and other important measures like happiness and depression. Importantly, because some people worry about, well, what happens if I exercise when I have an active cancer? They found no risk of increased disease or progression. So all of these things, we're really interested in how we can help patients improve their fitness. And we also wonder, why is it that this improves patients' fitness? And there are many reasons for this, you know, just improving your cardiovascular health. But one reason is that your immune system is really important for fighting cancer off. Even though that's kind of where the problem is in CLL, one area. One of the ways that we help fight cancer is every day your body's trying to protect itself from cancer. And so this is a very technically complicated slide, and this is not for us to go over all in depth. But my point is that we looked at the data of how exercise benefits the immune system in patients without cancer. And then we said, well, our patients have problems with their immune system, so how might exercise help them? And that's what we're looking at here. And the whole point of this slide is that exercise might not just make you feel better, but it actually might. And this is things that we still have to prove. We're still just looking at this information, but it was interesting and potentially exciting. Might actually be able to help your immune system work better and help you be able to work on your cancer just by the exercise itself, because it helps your immune system function at its more peak level. So it's looking at all these different cells, all the different, well, how I explain it as the military, which is your immune system. So your infection fighting cells on all levels, and how exercise can potentially help enhance their capabilities like it does in people without cancer. So what did we do? So we did HIT, which is called high intensive interval training in older adults with treatment naive CLL. So to start off this pilot study, which means it's just an initial feasibility study, just to get some data and hope that it works so that we can do it in a bigger scale, is we looked at patients who were not currently undergoing treatment and said, what if we put you through intense exercise? And so this is what we did. We assessed 25 patients, and we ended up having 18. We had 11 people go through the high intensity interval training, and then we had 7 go through control. Part of how you got put in each group was based on how far you live from the center, from our cancer center, because of course people that were living far away couldn't necessarily travel to us 3 times a week to get exercise in this current study. And one of the reasons the numbers were a little different, we usually like to match the numbers, is just because COVID unfortunately happened and we had to shut down early so that we were able to finish the study because of COVID restrictions. But this is what we did. So we had people recruited, and then what we did is we put them through a battery of testing. And this is something called the CPET. And I have to talk about it because it's really cool. Professional athletes use it. And the way we measure how well your cardiovascular, or that aerobic testing we were talking about, that VO2 max, of how efficient your body can pump blood and work hard, is by measuring the CO2 you produce when you're exercising. And so we actually got our patients to be able to do these tests. This is really cool because they were using the same equipment that the Duke basketball players were using. Actually, a funny story, the Duke basketball players, they have to put them in a sling because they can get so competitive with each other that they'll work till they pass out. Of course, we never let patients do that, but it's that level of testing how well someone's cardiovascular fitness is. So then you get put in this 12-week intervention where we put you through exercise 3 days a week versus our control group, which they were given kind of the general recommendations for what to do for exercise by the US task force, but no prescription like we're giving. And then we repeated all this testing, your strength, this cardiovascular testing, which is the CPET, did your blood samples, and then you were doing whatever you wanted to do for 12 weeks, and then we tested you again. So here's the exercise prescription. And this is one of the things that I think is exciting is it's really hard when you get diagnosed with a cancer. You either are started on treatment or you're started on dynamic monitoring for CLL, but you want to know what you can do. And just like when we give you a prescription for treatment and there's very precise, we think it would be really exciting if we could also give you an exercise prescription or a nutrition prescription. And we are far from that, I want to say, but we are starting to make some progress. So what our patients did was they did a 5-minute warm up, and then they did a 60-minute exercise session twice a week. And then the other exercise session was a 30-minute. Each of them had the 30-minute high interval training. And then the one session was that alone, and the other 2 sessions then also had 30 minutes of strength. So this is intense training, and I want to say, and we'll go to the results, but the high intensity interval training was 60 to 90 seconds of high intensity training, meaning your heart rate was going to be to 80 to 90% of that max cardiovascular capacity that we tested with the CPET that I just showed you. How hard could you work? And then you get active recovery. So you're not resting, but you're much lower at your cardiovascular respiratory state. So about 50% of what you could do if you were running from a cheetah. Strength was then, we tested it when we did the initial testing, we maxed out how much could you possibly lift. And that was, and then what we would do is then you would have to do a certain amount of repetitions at this 70% of that level. And then as you increase strength, once you're able to perform 20 or more of those repetitions, then we would increase the amount of you would be lifting at the next time. And then we would cool down. So this is what we found after all that intensity, that 99%, almost of every prescription was completed amongst our patients. So 100% of our participants were completing high intensity intervals at the prescribed heart rate. They were getting there, they were really exercising. And what was amazing was, even though we had ages of all ages up to even in their 70s, there were no serious major injuries at all observed. Although I will say 100% of the participants did report some minor muscle soreness due to this increased activity. So what was exciting about this is that it was completed despite it being a high intensity. And what we found, so in our strength testing, we did leg press, chest press, and seated row. And the reason we chose those as those are major muscle groups. So we were really activating major muscle groups in the body, and strength significantly went up. So maximal strength, which is how much you can do just with 1 rep, and then endurance, which is how much you can do with a multiple repetitions, all went up significantly, and some were even over 50%, as in this chest press here. And then what's really cool is we took people's blood work and took some of those infection fighting cells that I was showing you that picture about. So the NK cells, for example, which are natural killer cells, so their name implies it all, that in our bodies are floating around to be able to fight off infections, help protect you from cancer, things of that nature. And we tested them against other example cancer cell lines. And we found that they functionally worked better against these cell lines in the people that were participating in this intervention. Now, the interesting thing is we found actually that our aerobic capacity did slightly decrease in actually the people that were in the intervention versus the people at home. And part of that, I think, is that, you know, the people that were interested in participating in the study, that group were doing a lot of physical activity at home because they were so excited about it. Even if they were not in the intervention arm, they, you know, if we look at what they were reporting, had increased their activity because they were excited about this option. So some of this is just bias. And what happens, of course, is we're not going to tell people not to exercise, even if they're not in our arm of the study. So some of this is likely because patients themselves started doing some more activity. And so one other thing I want, before I get to conclusion, is that exercise can be beneficial in a number of domains. So when I highlighted at the beginning, it's not just one thing. It can help in multiple areas. It's feasible and safe. Now, I will say, if you're going to be doing high intensity things, you should always talk to a doctor to make sure it's specifically safe for you before you decide. But what I want to highlight with these is this, while low intensity exercise is great, they're certainly beneficial. Any activity is beneficial. But some people are more nervous, and understandably nervous, about, can I do higher level exercise? And the answer is, if it's done in a supervised manner, it seems from what we're looking at that is absolutely safe. I will say, we had a patient that had never been in a gym before coming in and was now exercising post-therapy regularly on her own. We had a patient that was on a walker before they started exercise. And that's what I really like about this is, as you saw from that prescription, is it's really targeted to where you start off. Whatever your baseline is, we then tailored the program to you and how you can max up your intensity level. And then the last thing is, there may be some significant immune benefits. We're still working on that may be really beneficial in patients with CLL, given the nature of the disease. So overall, as to the title of the slide, stay moving. Get involved in physical activity and exercise. There are lots of benefits, and we're going to be exploring a lot more how these benefits in the future, bigger studies may be coming, and exactly how they benefit our patients.
Dr. Sitlinger, that was really great. Thank you for sharing your information with us about the importance of exercise for people living with cancer and your study in CLL, about high intensity interval training. And we've got a ton of questions about this, so I can't wait to get to it. Let's jump into the Q&A, because we have a ton of questions here, and I'll ask Dr. Sitlinger and Dr. Saxe to turn their cameras on and their mics back on. And there was a question, and I'll go with Dr. Sitlinger on this one, but Dr. Saxe or Glenn, if you want to jump in. One patient, actually the very first question that came in, was about a patient who was advised not to drink green tea while on ibrutinib. And then there was a later question about supplements and being on a BTK inhibitor like curcumin or other supplements. Is there concerns about this? What do you advise your patients about drug interactions? This is something that comes up a lot. So why don't you start with that, Dr. Sitlinger, and then maybe Dr. Saxe, you can respond to this too.
Absolutely, and I understand it's hard, because I think we tend to lump treatments that are prescribed through insurance and supplements and vitamins in two totally different categories, and forget that actually they're all getting ingested by our system and metabolized by one body. And so what happens is, when you start a treatment, we look at everything that you're taking, supplements as well as vitamins, as well as your other medications, to see what interactions they might have. And so that's really what I would recommend, is you want to make sure that what you bring in your whole list, and then work with your pharmacist. That's what we do, is work with our pharmacists to see what interactions might occur, because what happens is they can compete for metabolism and, for example, the liver, and then you can actually get increases or decreases of the medications or absorptions and things of that nature. So it's really hard to do a one size fits all because everyone's medication lists are so different. But what I would recommend is that anytime you're thinking about it, whether you're on treatment or not on treatment, as far as a pharmacologic, work with your pharmacist to help understand the interactions, because usually that's the problem, is there might be an interaction driving an issue.
Gordon?
I'd like to just jump in for a moment and say that you may have noticed in the poll results that there was a lot more interest, or not interest, but use of supplements than there was of diet, which I found interesting. I am a minimalist when it comes to supplements and start with diet. I think that's much more the foundation than extracted components or synthesized ingredients in the form of supplements. Not that there isn't a time and a place. And therefore, what I would say is stick with, or make the emphasis on what we were evolved to eat, which is food, more than pills. And you're perhaps getting enough pills already with medication, and focus on the food. It's usually in a less concentrated form, less likely to cause harm, and more likely to result in benefit than any supplement.
Glenn, you want to add something to that?
I'd say that food first is a good way of thinking about it, because of the bioavailability of whole, fresh foods. When it comes to an agent such as EGCG, to get any kind of potential response, clinical response, it's going to be hard to drink as much green tea as you might want to get that amount of agent, in your body. And so by speaking to your hematologist and speaking to your pharmacist to ask specifically what those contraindications may be, specifically, why are you suggesting that I don't take EGCG with this BTK? Get those answers, because often, if a hematologist or treating oncologist will just say categorically, don't take anything, don't take any supplements. So it's good to get the data.
I would just add that, and the question was specifically about green tea. I think that there's no problem drinking green tea with any of the meds used to treat CLL. If you want EGCG, yes, talk with your doctor about that, because there are potential issues. But if you want to have a glass of green tea or black tea or a cup of coffee, go for it. And while we're on that, here's a question, and I'll start with you, Gordon. Alcohol consumption. Patients are told not to drink at all. Is alcohol consumption a risk? Does it make cancer worse? What do you advise your patients about alcohol consumption?
I would say that I don't think of alcohol as a health food, first and foremost. I also know that it's been used since antiquity, and it does have some redeeming values, mostly social. And I would recommend that people minimize their use of alcohol, but rather than making anything verboten or forbidden, I would rather say emphasize the positive things that you want people to do, or that you yourself want to do, and focus on that. And then in the overall context, try and, for whatever your starting point, minimize alcohol, if not eliminating it.
Let me ask another thing while we're on the food area that's come up in all different ways. The questions around fasting, intermittent fasting. They mentioned Victor Longo's research in fasting. And I see a number of people nodding their heads. I don't know. Dr. Sitlinger, do you want to start with that one on fasting? And what do you think about people doing intermittent fasts to help? And there's some data in other cancers that, you know, when you're fasting, it helps with the treatments that they're getting, the chemotherapy and stuff. So I'd be interested in and maybe do a roundtable take on this. Yeah.
I think this is just a challenging one because we just don't have a lot of data in CLL or really hematologic malignancies yet. There's certainly data in some other cancers that there might be benefit. I think one thing that's hard for hematologic malignancies or all cancers in a lot of ways is we're also balancing patients that are losing weight unintentionally, are struggling with their nutrition status otherwise. And so that does not necessarily mean there isn't a role for intermittent fasting. It's just we need better trials to truly say one way or another when I've looked at the data. And I don't want to give a non-committal answer, but I don't want to dismiss it. It's just that we just need more information on how to do it safely and what it actually might do. But there is a rationale, and other cancers are starting to show some promise.
Gordon or Glenn, yeah.
Yeah. So, yeah, I think the work of Walter Longo at University of Southern California is quite intriguing. And there definitely seems to be some benefit of intermittent fasting. There are many different forms. It could be a prolonged overnight fast of more than 12 hours without food, 8 of which you're probably sleeping anyway. Another approach is 1 full day a week. Others will do maybe a short fast or a longer fast of 3 to 4 days in a row. And some will do a very long fast, maybe a couple of weeks. Those longer fasts, I think, could be problematic, and I would not engage in any of those without doing it in the consultation of your physician or healthcare provider. But short fasting, like prolonged overnight fasting, is healthy for almost everybody. And we often will make patients go without food for a certain period of time in the hospital who are quite ill, and people can usually tolerate, you know, without any problem, you know, 12, 14 hours without food. That seems to be very good for metabolic syndrome, for reducing blood sugar, for helping with body weight, things like that, which are also concerns for many patients with CLL. So I guess what I would say is, I think it's pretty safe to just simply extend your overnight duration by a few hours and aim for at least 12 hours without food. And that's a very healthy practice for many of us. And but then if you go much beyond that, it should be with careful guidance.
I have some questions on exercise here. And if you want to do this high intensity interval training, so there's a couple questions. We're worried about going to the gym. So what do you tell your patients in the COVID era about going to the gym? And if they don't go to the gym, how can they get this? Is there a website? Is there an app? Is there something you advise patients? Because I think it's one thing to do some light exercise, but you point out the high intense interval training. You really want to have somebody who knows what they're doing guiding you in this. So what do you tell your patients who aren't at Duke University and part of your trial?
Absolutely. So I think there's a number of ways to get at this. One, the COVID concerns are real, and we totally understand that. So depending on where you are, there are gyms that have COVID restriction hours, where they have this, everyone who's here, it has a special reason to be extra concerned, or they may have restricted numbers. So you can look into what kind of options might be in your community that make it safer than maybe other times in the gym. And, everyone's going to have their comfort level. If you're absolutely not comfortable in the gym, which is completely understandable, you can actually do this at home. So you can do this body weight training in high intensity intervals. You can also even just use free weights. There are lots of different resources. There are free high intensity interval apps that you can get. And really what you need is a watch that has a heart rate on it. And then and an ability to time yourself there. There are various trainers that can help with this. And then there are also resources in the community that for example, I know the YMCA has programs that are free for cancer survivors that you could tap into regarding exercising and getting started. Again, well, and while that may be the Y, it might be a location you have to go to. I don't know what some have explored doing things from home too. So there's lots of different resources. Again, I do want to emphasize making sure that it's safe from a medical perspective, because it is high intensity training. But I do agree, whether it's a trainer, a physical therapist, a program in your community, but finding someone to help you get started, and really, but the key equipment is really having a watch or something that measures your heart rate so that you can make sure you're hitting those high intensity training intervals.
A lot of us have pulse oximeters now that we got for COVID at home, we've advised, which also takes your pulse. Glenn, a couple questions on your remarkable story. First, do you know what your markers were? I know they don't do them in the 90s. They didn't have markers back then. Do you know what your markers are now, or do you have enough disease to do that? And do you consider yourself cured? And people wanted, again, I know it's an N of 1, but wanted to know a little bit about your diet and exercise program.
Sure. The prognostication assays, all the genetic, the fish, et cetera, didn't exist back in 91. By the time IGHV was checked, it was mutated like in 2010. So it was likely mutated the whole time. As far as the other markers, they were all normal by the time I cleared my marrow. So unfortunately, they didn't exist. I did want to make a comment on the intermittent fasting. I have been doing that for over 3 years, 16 to 18 hour typical intervals. I didn't do it for any kind of underlying kind of malignancy. I did it because it just makes me feel terrific as far as the energy that it gives me and what I feel it does for me cognitively, and for a whole host of other reasons to kind of, not work my digestive system all the time with those 3 squares. And I too have followed Longo's work and Thomas Seyfried's work, and it's pretty brilliant around GBM and pancreatic cancer. It's still new, it's still evolving, and there's a lot more that needs to be done there. What was the other question, Brian?
You consider yourself cured, and if you can talk a little bit about your diet and your exercise program, personal. People want to know that. Yeah.
I don't use the word cured to describe my current situation, because I don't find it all that useful of a word. So I feel that I'm healed, and I don't really know what cured means in the context of cancer. 10 years out, 15 years out, you have breast cancer patients 30 years later have a recurrence. As far as my lifestyle, it's a lot of movement, a lot of physical activity, plant strong nutrition, with the only animal protein being cold water, omega-rich fish. I work on, sleep hygiene, clean hydration. I do various things to stay as relaxed as I can, and some well-placed supplementation that's informed, minimally evidence informed.
Thank you. It's, I know you a little bit, and I know you're a very disciplined person in terms of your diet and exercise, and good on you for that. I do have one out of the medicine cabinet question for you, Dr. Sitlinger. What's the role of the MRD testing? I'll just sneak that one in. Somebody asked that. We're not going to get to all the questions in CLL, but somebody did ask a general CLL question. You want to talk about measurable minimal residual disease testing and how you see that in the clinic outside of a clinical trial?
Absolutely. So that is another evolving space. We are really moving towards minimal residual testing, which means you can get most assays are 10 to the negative fourth detectable. Let me just throw that out there, that the definition, depending on what you're looking at and how it's measured, but very deep testing. And the reason that's really come into focus is in the targeted era. Initially, we were just you were on a BTK, for example, indefinitely, and as long as it was working and you were tolerating it, you were on it indefinitely. And now we are looking at how do we have time-limited therapy. So many of you may be on time-limited therapy right now, for example, venetoclax and obinutuzumab. And so now we're trying to target that even further with, if we are MRD status, what does that mean and how long can we predict that you're in a remission? And basically maximizing remission while minimizing the amount of time you are really in treatment. This is all still in trials as far as how to use it. So clinically, we are doing it at Duke in a lot of different ways, but from a clinical standpoint, we don't have, we're not utilizing yet, for example, a tailored duration yet, but that might be coming, or is coming, and we're working on it. And then how to maybe continue to use it in the future for response. But it's coming, it's exciting, because what we're hoping to do is truly going back to quality of life and all of these interventions, that how are we maximizing your overall health, right? Your exercise, your nutrition, and how do we minimize the time that you're on a medication, as I think Dr. Saxe said, a minimalist as it comes to medications, which is great. So that's how we're moving forward in it. As far as it is used a lot in trials. Clinically, we are using it help guide decisions, but there's no hard rules yet.
So I have to apologize to the people whose questions I didn't get to. There was great questions on the microbiome and antibiotics and vitamin D supplement, salt and mortality rates. They're just great questions, and we'll try to answer those for you offline. But I wanted to give everybody a minute here or less to kind of give a summary of if there's any takeaway messages or anything like that. Dr. Saxe, could you begin and just kind of give any kind of final punch that you want to people that they might have hopefully learned from this session? Yeah.
I'm extremely optimistic about the potential for diet and lifestyle change to have a huge impact on cancer in general, on a variety of other chronic diseases. And while we haven't proven it with CLL, I think it's a very important topic for investigation. And we at UC San Diego and others are starting to look into this with clinical trials. I greatly admire Glenn and what he has accomplished in his own life and what he's taught other people. He is really quite the poster child. And what we were doing in our prostate cancer studies earlier was very much similar approach to what Glenn has incorporated in his own life. I agree with Glenn when he said that he can't claim that he's cured just based on the initiation promotion theory. He may have removed lots of promoting factors and the cancer has gotten to the point that it's gone from all detectable measures, but it doesn't mean that the susceptibility, the genetic susceptibility doesn't remain. So for somebody like Glenn, or for most of us, it's important to be on guard because we all harbor susceptibilities to diseases. And I think the same set of factors with diet and lifestyle and physical activity are going to be beneficial regardless of what we're dealing with. And it's important for us to avail ourselves of the best possible treatments, to be on top of those things, but also to do things to be proactive and help ourselves. And I see no harm when one is watchfully waiting to be doing these things proactively. Only benefit.
Thank you. Glenn, I think that sets you up for the next, if you have any thoughts to say.
And I could echo much of what Dr. Saxe just said. For those that are in watchful waiting and those that are even on active treatment, there's no better time than now to just start taking care of the host environment. We have the tumors. that we've come a long way with the therapeutics and how they're targeted. The host environment, that's each of us as an individual. We are all different, just like the tumor burden is different. And it's just a wonderful time to start taking care of our bodies and to increase our immune function and our resiliency, whether it's for underlying diagnosis of CLL, or it's the next COVID or the next pathogen to come. There's no downside from taking better care of ourselves.
Last word for you, Dr. Sitlinger.
And I need to echo my esteemed colleagues here that truly it is, when we're looking at CLL, it's not just that one cell, it's your whole body. And so if we can look at and think of it as how can we use every tool in our toolbox, it's not, even if you're on treatment, then how can we still enhance your, potentially even the treatment? That's what we hope to study in the future, is how can we use these things even if you're on treatment? So whether on treatment or on dynamic monitoring, think about how you can use every tool in your toolbox to make your health the best it is possible, not just for the CLL, but also for how you feel in general in life.
I think this has been an amazing webinar, and thank you to our faculty. This program was made possible by, and I want to thank AstraZeneca, Pharmacyclics, and Janssen for their support. I want to thank all the attendees. Just to remember to take a moment to complete our post-event survey. I want to really thank the faculty again. I mean, they just did an amazing job on this. And I wanted to put a special thanks out to Glenn. Glenn has generally made his book, N of One, which tells his story. He's made that available, a downloadable version of that available for free to anyone who's interested through May the 10th. But I join Glenn in encouraging you, if you found this worthwhile, and Glenn's generosity worthwhile, consider making a contribution to the CLL Society when you download the book. But let me be clear, that's not necessary. Please, this event was recorded, so it will be available to you. It's generally in about a week from now that it'll be up. If your question wasn't answered, please send it to Ask the Expert. That's all one word, Ask the Expert at cllsociety.org. Ask the Expert at cllsociety.org. We have on May 16th an upcoming webinar on clinical trials. Many of you know Dr. Adrian Wiesner of the National Institutes of Health, and he'll be leading that, plus a patient who's been involved in clinical trials, plus a nurse navigator who's going to help explain what goes on in clinical trials. So thanks to everyone again. The CLL Society is invested in your long life. Please invest in the long life of the CLL Society by supporting our work. Stay strong. We are all in this together. Thank you to everyone for their time and their attention.